Good morning, everyone. My name is Zoe Shi. I'm a hematology-oncology fellow from Mayo Clinic in Minnesota. Thank you so much for the MDS Foundation for this great opportunity. And our talk today is entitled Anemic Patients with CCUS. I have no financial relationships to disclose. So let's start with a case presentation. So let's say a 73 years old gentleman comes to you with persistent anemia for 6 months, and his CBC reveals low hemoglobin of 11.9. He has normal MCV, RDW, WBC, and a platelet count. An extensive workup for anemia has ruled out other etiology of anemia. So a bone marrow biopsy was obtained and shows slightly hypercellular bone marrow with translineage hyperplasia, no atypia, no morphology features of myeloid neoplasm. He has normal cytogenetics. And the next generation sequencing showed the type 2 mutation with a VAF of 36% and the DRSR2 mutation with a VAF of 38%. So he was given a final diagnosis of clonal cytopenia of undetermined significance. So today I'm going to discuss CCUS with you by talking to you about the definition, the prevalence, and their phenotypic data of the clonal hematopoiesis and the clonal hematopoiesis of indeterminate potential and a clonal cytopenia of undetermined significance. We will also talk about the risk stratification of the CCUS. And then we will learn about the clinical trial opportunities that exist for our patients with CCUS. So at the beginning of the talk, I gave an example of the older adults with anemia. So the prevalence of anemia increases with age. For people who are 65 years old, the presence of anemia is about 15%. And the prevalence increases almost to 50% for patients who reached to 90 years old. So the anemia in older adults is common and relevant. For example, in this paper published in 2017, where the authors evaluated more than 100 of patients with anemia, where they find that almost 50% of the patients' anemia is unexplained. So it poses new challenges to our health system. So for the past few years, the next generation sequencing is widely available in most settings. So patients with unexplained cytopenia are increasingly undergoing the next generation sequencing molecular genetic testing for diagnostic purpose. So the next generation sequencing has significantly improved our diagnostic approach. So having said that, the comprehensive sequencing data also yields many indeterminate or unactionable information. This gives rise to a new concept, which is clonal hematopoiesis. So the clonal hematopoiesis and its related topics, including CHIP and CCUS, are rapidly changing, and it becomes a very exciting field. So as a hematologist, it is very important for us to understand CCUS, which is a precursor state that may evolve to heme malignancy. So first of all, the clonal hematopoiesis is defined by the acquisition of the somatic mutation in the hematopoietic stem cells in apparently healthy individuals without underlying hematological neoplasms, with the potential to expand over time. And the terms of CHIP describe the somatic mutation in leukemia-associated driver genes in the hematopoietic stem cells with the variant allele fraction of higher than 2%, without evidence of underlying hematological malignancy, and also without a persistent cytopenias. So if the clonal hematopoiesis occurs in the setting of the unexplained cytopenias, but without overt features of an underlying hematological neoplasms, and then the condition is termed CCUS. So how frequent is CHIP? It really depends on what technology we're using. So here is a figure that summarizes the depth of the sequencing from a few large population-based studies. It shows you that most of the study have a sequencing depth of 1%. But if you sequencing really hard at a deeper level, you may find more patients with CHIP. But overall, in this figure that we can see, CHIP is very rare for patients who are younger than 40 years old, but a rise in frequency every decade thereafter. So in 2014, this New England Journal of Medicine paper, it was found that patients with CHIP, 93% of them, they have only one mutation. And the CHIP mutation are frequently involved the epigenetic regulator genes, including the DNMT3A, type 2, and ASS1. The median VAF of this identified mutation was 1%, suggesting the variant are present in only a subset of the blood cells and supporting their somatic origin. So CHIP is associated with heme malignancy, but it is also associated with all cause of mortality and also cardiovascular disease, largely driven by the endothelial dysfunction. So we as a hematologist, the ability to accurately prognosticate who will evolve to heme malignancy is an essential. So as a reminder, clonal hematopoiesis refers to a clone population with the potential to expand or under the influence of a driver somatic mutation, conferring a growth advantage. Or a mutation clone is more fit to survive under the pressure of the hematopoietic environment. Then it can progress into the myeloid neoplasm through the acquisition of subsequent subclone driver mutations. So there are a group of genes whose mutation will increase the hematopoietic stem cell self-renewal and magnified as clonal hematopoiesis. So they are broadly fall into three main classes. One is the epigenetic regulator genes, two is the splicing factors, and three is the DNA damage response genes. So what it really tells us is that the progression from the normal hematopoiesis to the malignancy is mutation dependent. So actually, there is only a small proportion of patients will progress from the CHIP to CCUS. But in the context of the cytopenia, two studies reported a high prevalence of the somatic mutation in patients with cytopenia. So one looked at the prevalence in the context of anemia and found almost 50% of the individual with anemia harbor somatic mutation. And the other look at the prevalence of in the context of ICAS, and it was found that almost 30% of the patients in this group had the somatic mutation. So the mutation were a spectrum of the mutated genes, largely, if not completely, overlapping with those genetic mutations observed in the MDS. So although only a small portion of these patients with CCUS will progress to heme malignancy, it was found that patients with CCUS had a probability of developing a myeloid neoplasm that was 14 times higher than that of patients with no evidence of clone disease. So in terms of the mutation patterns in the CCUS, it was found that the type 2 was the most common mutation in CCUS population, followed by the ASS1 and the DNMT3A and the splicing genes. So it was also depends on what kind of study population we're looking at. So with increasing age, a relatively higher proportion of somatic mutation in type 2 and ASS1 were observed compared to the DNMT3A mutation. Regarding the number of mutations, first of all, by definition, patients with CCUS, they should have at least one somatic mutation. In this figure, you could see a group of patients had at least 2 mutations. And what are the most common combination mutations? It was found that the epigenetic regulator genes combination and the SRSF2 with other mutations are commonly seen in the CCUS population. So regarding the variant allele fraction, so research has found that patients with CCUS, their VAF is not significantly different compared to patients with low risk of MDS. And in our group, we look at the 6 most common mutations in the myeloid malignancies, and we found that there was no difference regarding the VAF between the CCUS and the low risk MDS, except the DNMT3A and SF3B1. So now I'm going to discuss with you how to risk stratify patients with CCUS. So in 2017, it was found that patients with more than one mutation are at a significantly higher risk for myeloid malignancy progression. And at a 5 years time point, almost 80% of the patients will progress to myeloid malignancy. Further, a high-risk group is also defined. There are a group of patients with spliceosome gene mutation and co-mutation with epigenetic regulator genes who are at a significantly higher risk for myeloid malignancy progression. So over the years, we have learned that not all the patients with CCUS are the same. So we have learned that the number of mutations, the VAF, and the pattern of the mutation matters. So let's talk about the number of mutations first. In the left upper figure, I shows you that the distribution and the cumulative incidence of progression to myeloid neoplasm according to the number of somatic mutation. So what is found is that detecting more than one somatic mutation had a positive predictive value for myeloid neoplasm of more than 80%. And the bottom left figure shows you the Kaplan-Meier curves of the overall survival according to the number of mutations. And you can see patients with 3 or more mutations are at a significantly higher risk for inferior overall survival. So the figure on the right side gives you an example of the distribution of the genotype complexity according to the number of mutation for the individual with the AML compared to the normal control. As you can see in the case of the AML, the co-mutation is very common and complex, but in the control, mutations are generally presented individually. Regarding the number of the mutation, patients with the AML also has a higher number of mutation compared to the controls. So the second important point is the VAF. So in this figure, as you can see, the higher the VAF, the worse the outcome. So more importantly, the VAF is changing dynamically. It is not a snapshot. For example, the VAF of the DNMT3A increases 5% per year, and the VAF of the type 2 increases 6.8% per year, compared to the SRSF2, which is even higher, 15 to 20% per year. So it was found that not only the mutation matters, the specific mutation hotspots and the mutation type matters. For example, the hotspots of the SRSF2, the P95, grows at an even faster rate. And the TP53 missense mutation increases 10% per year comparing to the truncating mutation, which is relatively stable. So the clonal hematopoiesis growth rate varies and is highly associated with leukemogenesis. So here is the figure as we discussed that the mutation hotspots matters. In this figure, we can see that the DNMT3A R882, the NPM1 W288, and the NRAS G12 are highly associated with the AML. And whereas the SRSF2 is highly associated with the CMML. So most recently, this interesting paper shows that the CHIP mutation can be classified into two clusters. So the first cluster mainly comprised the individual with clones driven by isolated DNMT3A mutation. The second cluster mainly comprised the individuals with mutation profiles involving the splicing factors TP53 or DTA genes in combination with additional mutations. So these two clusters are significantly different from each other regarding their number of mutations and the VAF of the mutation. They also have significantly different impact on the overall survival and disease progression. So in this figure, as you can see, patients with MN-like cluster had a higher risk for progression and had an inferior overall survival. So we initially thought that the CHIP is a myeloid-associated genes. And as we speak, in this paper, just published recently in the Nature Medicine, shows that the CHIP can be classified into myeloid CHIP and the lymphoid CHIP. So in the upper part, it shows you the myeloid-associated genes, and in the lower part shows you the lymphoid-associated genes. And the lymphoid-associated CHIP is also an age-related phenomenon. And it is striking that the lymphoid CHIP is associated with high risk of lymphoid malignancy, such as CLL. So I hope that I showed you some of the new insight of the information about CHIP and CCUS. And you may ask me, what do you do for patients with CCUS? So currently, there is no FDA-approved treatment for patients with CCUS. Now let's learn about the clinical trial opportunities now. So I'm going to focus on two interesting studies in this talk. The first study is using the ascorbic acid in type 2 mutated CCUS. This is a phase 2 interventional study conducted at Mayo Clinic. So what we have learned is that the TET enzyme is an important enzyme in this DNA methylation and demethylation circle. And the TET function is vitamin C dependent. Based on the preclinical work where we have exposed the lymphoma cell line to ascorbic acid, and it's found that the ascorbic acid could enhance the TET function and also the first product of the TET enzyme, which is 5-hydroxymethylcytosine. So because of this preclinical work and also the phase 1 study, we have proposed a phase 2 study where we are using the high-dose ascorbic acid in TET mutated CCUS. Our primary endpoint is to determine the impact of the ascorbic acid on the cytopenia, and the secondary endpoint is to evaluate the impact of ascorbic acid on the epigenetic modulations. The next study I want to show you is that using canakinumab in CCUS. So the idea is generated from the CANTOS trial, which showed a reduction in major adverse cardiovascular events in individuals given monoclonal antibody targeting the IL-1 beta. So a subgroup analysis found that patients with CHIP, especially the type 2 mutation, had a better response to this drug. So the research has found that the type 2 deficiency in the hematopoietic cells is associated with greater cardiac dysfunction in murine models of heart failure because of the elevated IL-1 beta level. So CHIP has been linked to ischemic heart disease, heart failure, aortic valve disease, with the inflammation identified as a key mechanistic node. So currently, the investigator from OSU has proposed a study using canakinumab for inflammation inhibition for patients with CCUS. So we are very much look forward to seeing this study open shortly. Because of the time limitation, we will not be able to share more studies, but there are also studies focusing on using the IDH1 inhibitor and IDH2 inhibitor for patients with IDH1 or IDH2 mutated CCUS. So I want to end up with my talk with showing you the CCUS consortium collaboration. Currently, we have established a CCUS consortium with 30 more cancer centers. For this effort, our primary aim is to describe patients with CCUS, their clinical characteristics. We also want to describe the progression outcomes and also to identify risk factors for progression. With a longer follow-up, we plan to describe the clone evolution, the dynamic changes of the valve, and also to describe the survival outcomes. So here is a snapshot of some basic information. But for more information, I will share you more information about the CCUS consortium finding during the ASH poster session. Please pass by and I look forward to seeing you there. Last, I would like to give my deep appreciation to my CCUS consortium investigators. It has been a great pleasure and a privilege working with you. I also want to give my special thanks to my mentors, Dr. Savona, Dr. Panek, and Dr. Akali. You are phenomenal mentors. Thank you so much for your guidance. And last but most important to my audience, thank you so much for your attention. Please contact me if you would like to join our CCUS consortium. And stay tuned, more exciting work and intervention are in the pipeline. Now I'm open to answer some questions.